Welcome, Ian. We are very excited to have you with us, and I will turn the time over to you.
Alrighty, so we know that the economic burden to individuals who sustain an ACL injury is rather large, both through the United States and the world in general, as both the rate and incidence with which these injuries are occurring is increasing every year. Also, we know the outcomes for individuals that undergo surgical reconstruction or repair of this ligament, which from this point forward will be known as ACLR. They're not great and that they are not where we want them to be as clinicians or from a healthcare standpoint. And this doesn't even begin to account for the fact that about 30% of people, young adults and adolescents in particular, re-rupture this ligament after undergoing surgical intervention just a few short years after their initial surgery, with the highest reoccurrence rates occurring anywhere between the first 2 years of post-surgery. So the ACL can tear both due to contact and non-contact reasons, with the predominant mechanism of injury of the ACL being in a non-contact nature. The currently theorized underpinning of non-contact ACL injuries is that there's a sensory motor mismatch that the patient athlete suffers when competing, and this results in a cascade of neuromuscular dysfunction. So usually the ACL tears on the court or field of play and or sport when a patient athlete tries to suddenly stop during a deceleratory movement while changing directions or pivoting. This forces their knee into a valgus or inward moment and their hip usually into an adducted moment. The rotational stress occurred from these two movements can then overload the ACL and lead to its sudden rupture. While 70% or roughly 2/3 of the time these injuries are non-contact in nature, the other 30% are due to contact mechanisms of injury. And as much as we try to preach about robustness and resiliency as a part of our jobs as strength and conditioning coaches, physical preparation coaches, PTs, ATs, and so on, at the end of the day, if someone runs full force and full speed into someone else's knee while colliding with that lateral aspect of their knee, those forces can overload any tendon or ligament, including the ACL, and result in its rupture. This is part of the reason why there's no such thing as injury prevention in my mind, only injury reduction when we speak from a sporting perspective. So the literature currently only reports around 43 to 45% of individuals returning to their pre-injury level of performance status post-ACLR. And that's defined as performing at or above their pre-injury level in whatever their chosen sport was. If we compare this to return to sport rates, we have healthcare providers and clinicians are slightly better at returning patient athletes back to their respective sport, as we are able to perform this around 55 to 60% of the time. And this is defined as having returned a patient athlete to their pre-injury sport of choice, but maybe they're not performing at their desired level, AKA they're performing at a lower level. Finally, our current healthcare system is best at returning patient athletes status post ACLR back to a participation level. And this is defined as a level of sport that is lower than that which the patient athlete was at pre-injury. So major societal and healthcare problems from pathologies such as ACL injuries are always multifactorial in nature. Psychosocial factors and things such as a patient athlete's psychological readiness play a huge part into returning to sport or performance, as we know that fear of re-injury is the #1 obstacle for a lot of patient athletes. We also know that some families and individuals face healthcare hurdles from the system itself, things such as financial constraints, insurance issues, transportation difficulties, limited access to healthcare providers who are best qualified for this type of rehab, and so on. And then finally, from a provider level, no matter the discipline, whether that's AT, PT, SNC, and whoever else is engaging in this rehab, we know there's a lack of standardization and agreement between what we should be doing from an intervention selection and loading parameter standpoint, from a milestone attainment standpoint with regards to the phases of ACLR rehab, and from a measurement perspective with regards to monitoring performance and workload. So there's just a lot of disagreement with regards to what are the best performance measurements for returning patient athletes back to sport and the length of rehab itself, as some people advocate a timeline of 9 months versus 2 years. So in my opinion, with regards to loading a patient athlete, if we start there at that bullet point, really the goals and principles of rehab and physical preparation are the same, and the only real difference is the starting point of the patient athlete. So as a quick recap, we know we can train things such as isometric strength at 0 velocity, quasi-isometric strength at very low velocities, strength speed at low velocities, speed strength at intermediate velocities, and explosive strength at high velocities. And we can use a wide variety of implements to accomplish the training of each of these quote unquote types of strength, as most athletic activities occur at speeds that preclude peak muscle force. And due to all strength qualities lying on a continuum, each quality can be trained with general recommendations over a range of intensities versus only within one specific small zone. However, it should be noted that for peak athletic performance, some qualities should probably be trained to a greater degree than others, although training all of the qualities at some point in time is warranted. So maximal strength on the force velocity curve can be trained with an intensity of around 80 to 100% of the patient athlete's maximum in whatever intervention we are talking about, versus strength speed, which can be trained at a maximum of around 60 to 85%, and then speed strength, which can be trained at an intensity of around 25 to 40%. Strength power is usually developed at intensities ranging from 55 to 80% versus power velocity, which can be trained at 25 to 55% of 1 RM. And this is not to say that training load is the end all be all, because it certainly is not, as other factors such as AMI, arthrogenic muscle inhibition, the central activation deficit, quadriceps activation deficit, maladaptive neuroplastic changes, and things of that nature play a role here. But the loading and dosage of our patient athletes are important variables that we want to make sure we're just establishing throughout the patient athlete's rehab. And as a quick recap, from a repetitions perspective, strength should occur in the 1 to 5 range, same with power, endurance in the 25 plus rep range, and then hypertrophy in the 8 to 15 range. The amount of sets we're performing per each exercise from a strength perspective is going to vary somewhere between 4 to 7, power 3 to 5, hypertrophy 4 to 8, and then endurance 2 to 4. So it's also important to note that there's more to programming than the sets, reps, and so on that I just discussed. And since most field sports have nothing to do with the weight room competitively, let's take a minute and talk about the loading parameters too from a metabolic and bioenergetic perspective. And this is relevant both for on and off feet conditioning in the later phases of a patient athlete's rehab. So in training the ATP-CP metabolic system, we want to make sure we give at least 2 to 3 minutes of recovery time between efforts, as the work interval is roughly 5 to 10 seconds in length. This comes out to a work to rest ratio that's somewhere between 1 to 12 to 1 to 20 in nature. For a fast glycolytic system, the work interval is of 15 to 30 seconds in length, with a work to rest ratio of 1 to 3 to 1 to 6. Contrasting that with the slow glycolytic system, the work interval of 1 to 3 minutes is needed, with a work to rest ratio of 1 to 3 to 1 to 4 in nature. And then finally, for our aerobic or oxidative system, this requires a work interval of greater than 3 minutes, with a work to rest interval of 1 to 1 to 1 to 3. So it's important that we just understand how to train all of these metabolic systems, no matter the method we use, as we all know that they are quote unquote on to a degree with any activity. And we definitely, with this rehab, don't want to shy away from training these systems that require more intense efforts, as it has been shown that exposing the body to close to maximum velocity speeds, it has a protective effect on lower limb injuries. Furthermore, there's studies showing that the more efficient an athlete is at running and sprinting, the less chance of them sustaining non-contact injuries in the first place, which is what I'll remind the viewers of this presentation and the listeners as being the predominant way that an individual ruptures their ACL in the first place. So the net effect of a patient athlete who suffers an ACL tear will be that they're going to be more reliant on vision and cognitive planning for movement. And they will simultaneously experience increased proprioceptive impairments and postural control deficits unless they become vision reliant for neuromuscular control. And it is for these reasons we really want to focus our patient athletes rehab on being on the removal of internal cues, such as visually looking at that joint for movement and contractibility, aka that mind-muscle connection, and more towards that entailing the integration of dual tasking and reactive decision making within the same exercise demands. And this could be implemented later on with simple proprioceptive or field drills that also involve both dual tasking and elements of reactivity through activities such as computing simple math problems, counting down from 100 by sevens, while using training technologies such as FitLight, BlazePod, and synaptic strobe glasses. Proprioceptive and field drills using synaptic strobe glasses also have the added benefit of impairing vision, as can some technologies that are virtual reality related as well. As for these reasons, and I'm laying out that, again, training load isn't the end all be all, at least in terms of a patient athlete's ACL rehab. But once we as providers address the patient athlete's rehabs and any and all deficits from AMI, maladaptive neuroplastic changes, and so on, which again requires a variety of measures and techniques, anything from BFR to NMES to compression and ice, sensory retraining, using again things such as synaptic goggles and other neurocognitive techniques which impair vision, then we can load patient athletes appropriately following some of the accepted principles I've just described. And it's really just important for the listener and viewer of this program to understand that movement is not just a hardware or biomechanical problem. It also involves the patient athlete's brain and behaviors, the software, so to speak. So generally speaking here, we can divide the patient athlete's rehab into an early postoperative phase, then into a strength endurance hypertrophy phase, a strength speed or power phase, and finally into a long-term athletic development phase where things such as speed strength and sprint ability are developed, along with a change of direction and agility drilling that's required for patient athletes to return to sport. Each phase of ACLR rehab will have an initial phase of protection before we really start to introduce load, and load introduction precedes, of course, accumulation of that load into more and more specific and intensive interventioning. Or said another way, we can progress individuals from general preparatory exercise to specific preparatory and developmental exercises to competitive exercises. So here's an old colleague that used to work for me. His name is Andrew. If I just go back to the beginning parts of this video, really what I want to start to establish are some movement concepts when we're teaching our patient athletes change of direction. So here Andrew's demonstrating really a linear three-step stop. I like to teach a lot of my change of direction mechanics in 3 steps. Have I taught them in 2 steps, 4 steps, or 5 steps as well? Sure. That's going to depend on the caliber of the athlete in front of me. But these 3 cones, the yellow, blue, white cone, they're just signifying where I want Andrew in this case to perform that 3-step stop. So we can see he's going to perform a right, left, right breakdown. So 1, 2, 3. And we can notice when he's breaking down into this lunge stop position that he's folding up like an accordion. His knee is over his toe, if not past it. For a lot of these change of direction maneuvers, the knee has to go over the toe. It's just a requirement. So obviously, before we even teach these change of direction mechanics, we have to ensure that the patient athlete's tissues are really, they have the capacity to perform maneuvers such as this, because they're going to have to do that. But he's keeping a joint, stacked lower extremity joint position, again, folding up like an accordion, knee over toe, and then he's pushing in an equal and opposite fashion his butt back. And I tell my patient athletes when I'm teaching these breakdowns that I should be able to close my eyes and hear you break down. And I should be able to really hear how many steps you take. Now here we're just using, so there's your 3 steps. Here we're just using a med ball to teach that retro reverse lunge stop. And we're using the med ball as a counterweight, but everything stays the same. And obviously at the beginning here, I'm going to constrain how far my patient athlete has to move when they're performing these breakdowns. So I'm going to start, closer to 5 to 10 yards, and then I can start increasing the distance that they're really translating through in order to perform these breakdowns. Now, I think we're all familiar with agility ladders, and I know we all have different concepts of its utility, at least from a physical preparation standpoint. Some coaches like them, some don't. You'll hear things like they teach patient athletes to go nowhere fast, AKA just teaches fast feet, or, the agility ladder will also get knocked in terms of it doesn't really replicate the rate of force or really just the force demands that the patient athlete encounters during their sport. And these are true. But when we are reconditioning patient athletes' tissues, at the end of the day, it's the 12 by 12 inch square that allows us to do that and really grade movement. Now with this icky shuffle, we're still going to stick with our 3-step stop thing here. So Andrew's going to perform 2 in, 1 out. So again, it's going to be quick, quick, and then stick. And we're just teaching this lateral shuffle stop now. And then we're going to progress that next to a crossover step. So when I'm teaching this, again, I'm just going to have my patient athletes count it out in 3s, and I'm going to tell them that the outside leg is the crossing leg. So here he's going to display that. So there's your first step, that right step. That's your second, and then that right is third. So 1, 2, 3. And I'm just going to let this play. And we're teaching good angles, good body lean there. So we go back here, we can see that, again, Andrew really has an imaginary line from that ankle through that shoulder. His shin angles are relatively parallel to each other. He's not really rotating through his upper body. So he's leaning towards where he wants to go because this is a closed drill. And then in this next drill, we're just letting him perform this with a little bit more while translating a little bit more side to side. And here's Kathleen, and she's really just showing a spin cut there. So it's still going to be 2 in, 1 out, teaching it in 3 steps, but now she's really pivoting through one of her legs. And if I just go back to show that again. Two in, 1 out, but everything stays the same. Knee over toe, butt back, good separation of the legs and arms. And then what we're going to do, just like we did with our linear 3-step lunge technique, I'm going to let Andrew shuffle, build up some speed next. He's going to go 2 in, 1 out. And it should be noted here, I'm using cones just so to signify things like an external hoop. If you have a hoop, feel free to use that. But now he's going to start putting it all together. So 3-step forward and retro now. And notice he is being aggressive when he breaks down, displaying good body lean, things of that nature. And we're going to perform the same drill just from a slightly greater distance now. There we've seen a left, right, left breakdown. He's going to display the same thing here. So left, right, left. And again, we can teach this in more than 3 steps if needed. We can see in these change of direction drills, he knows where he's going. So in this case, he's sinking his hips. He knows he's going to go back to, in this case, his left. So he has that good imaginary line from ankle all the way through shoulder, relatively parallel angles. Now, he's not going to be able to do that if we were doing shadow, mirror drills, things of that nature, because he would have to be more reactive. He wouldn't know where that opposing player is going if he's trying to follow them, for instance. But in these closed drills, this is a good method to teach just so we can get our patient athletes really understanding their angles. Now, in this drill, we're really trying to put everything together. So what we can see is Andrew's going to perform a left, right, left breakdown here. 2 in, 1 out, and then he's sprinting forward. He's going to display that again here. So left, right, left, being aggressive. And then when he reaccelerates after this makeshift hoop, we are going to see a big separation of his legs when he gets into his acceleration mechanics. So it should look something like that, where an imaginary line again is going from his ear all the way down to his ankle. We see a roughly 90-degree torso to thigh position. This torso angle is roughly parallel with this shin angle. Arms could get a little bit higher, but if we really drew it out, we should be able to draw almost this hashtag position if we are hitting our angles correctly for that linear speed when we're reaccelerating out of some of these change of direction techniques. There's Andrew. He's displaying a different type of spin cut using more of that T-step variation in that Jerry Rice drill. And this is just me showing and really in a separate video going through that spin cut. You'll see a lot of movement variances with our patient athletes, and that's okay, whatever strategy they want to use. And just continuing to progress things, making them tie in all these movement strategies together. Here we're performing a M drill. So we're going to still break down right, left, right breakdown, 2 in, 1 out here, and then reaccelerate forward. And there's a bunch of different M drills, which is why I like them. You don't have to change the cone configurations when you're teaching these. And there it is just again. Now we're going to perform more of this X drill. So the viewer here will see it's going to be still a 3-step lunge stop here, but he's angling himself. So we can see he's starting to really rotate his body, in this case to his left, because he's going to target this cone over here. So he performed a right, left, right, but instead of doing it straight ahead, he's starting to angle himself around that cone. And that's why, in my mind, this X drill would be the next progression from that M drill that I just previously showed. And this is just the same drill from a slightly different perspective, but there we see the right, left, right breakdown. And generally speaking, when I teach things like a 2-step breakdown, or I'm just teaching patient athletes to be more aggressive overall, I'm really reserving more of that type of breakdown for our higher level athletes, collegiate, professional, think there. Now, here's another M drill. Like I was saying, I didn't have to change the configuration of the cone, but we're going and really performing now more of our 90-degree cuts within that drill. So if I go back to it real quick, we can see 1, 2, 3. Eyes turn towards where the patient athlete wants to go on that second step. And then that third foot contact is behind the patient athlete so they can get a good push angle in order to really reaccelerate to where they want to go. So I can pause it here. So left, right, you can already see he turned his eyes towards where he wanted to go. And when this left leg comes down, it's going to come down posteriorly behind him, and you see he just pops out there to the next cone. Up next, we're really teaching more of our quick cut, I think 45 degrees or less in this Y drill. And you see Andrew's always leaning towards where he wants to go. So in that case, he went to his left, so right stick followed by left stick. And here we're teaching more of our 180-degree cut. So left foot is his first breakdown step. He's crossing with the right, 2, and then third step pops him out, and we can see he's just traveling the V there. So what movement strategies we want our patient athletes to perform just, again, can really be dictated by the configuration of the drill. Now here we're going to perform much like our patient athletes do this drill in with suicide, shuttle runs, things of that nature, that 180-degree crossover step again, or that 180-degree cut. So we see right foot contact. He's going to cross here with his left. His eyes are starting to turn where he wants to go in this figure 8 drill. Right stick in order to pop him out. The same thing here. So left stick, right, left. And then he'll just continue to do that. Okay, so we're trying to teach good movement mechanics using whatever system we want to. That's just a quick snippet of some of the systems that I use when I'm teaching my change of direction mechanics. But ultimately, we want to run some kind of periodization for our patient athlete and their phases of rehab, as this must occur for proper due diligence of us as providers so that we can claim that. And the textbook definition of periodization is that it's the logical, systematic approach involving the sequential alterations in workloads of a patient athlete in order to improve performance and attain whatever goal is of the patient athlete. So simply put, periodization is just really a method or model to manage the stressors that a patient athlete is exposed to so that the effects of fatigue don't overcast and outweigh the performance and fitness measures that we're trying to really develop as clinicians and coaches. And this general adaptation syndrome basically tells us that if we don't train stuff frequently enough, or that if we train certain performance qualities for too long and too intensely in combination with training too many characteristics at once, our patient athletes are going to become exhausted and experience overtraining effects followed by detraining effects if injury were to occur. Now, part of the reason we develop periodization models, as already previously mentioned, is we're trying to juggle so many demands of sport. And now on top of that, we're trying to juggle the demands of a rather intensive ACL rehab. And the fact of the matter is, as much as we want to focus on the sequencing of the physical abilities of our patient athletes, stress is cumulative. And whether that's physical, emotional, social, psychological, and so on, we have to account for that. And it can come from juggling relationships, school, work, sport, societal pressures, both real and perceived, and so on. And this stress can either fuel performance and growth through eustress, or it can lead to really re-injury ultimately through damage and disease because of distress and overtraining syndromes. And that's the whole reason why we try to run some type of periodization model, as training loads can be progressed over time as prior exposures to a stressor allow someone to tolerate a larger stressor in the future without experiencing exhaustion. And this is, of course, assuming that we as clinicians or providers and coaches systematically load patient athletes without large training spikes, thus enabling them to adequately adapt to the stressors placed upon them in the first place. Now, there's a whole lot of different periodization models that we can run in order to accomplish the goal of the patient athlete who underwent ACLR surgery. And that's ultimately to return to performance, not sport, performance. And in the barbell sports, we know there's a lot of debate and arguments over what is the best periodization model. And that's fine and dandy, because really, at the end of the day, most of these barbell sports have one specific day where that patient athlete needs to be peaked and ready to perform at their best. And this just is not true with most field sport athletes. Basketball patient athletes might have to play 2 to 3 games in a week. And if you're rehabbing someone who underwent ACLR procedure who plays soccer, oftentimes they play both for their school and club, and they're going to play multiple games per week as well. So a simple linear periodization model in season might not cut it or yield the best results for these types of patient athletes. So it's important, at least in my mind, that we at least have a surface level understanding of each periodization model so that the provider knows when and where to use that model. And probably the most basic model is the linear model. And in a linear model, we basically increase the intensity of training while reducing the volume of training over time when peaking for an event. Or we can do the exact opposite during an accumulation phase, aka we can increase the volume of training while decreasing the intensity. And this model is usually, generally speaking, good with beginners or just those patient athletes who have a low training age. Versus a block model, where periodization is basically focused from a microcycle level on one specific motor ability. So maybe we have a hypertrophy block, then a strength block, and next a power block, and we perform a 3-month mesocycle. Maybe we perform a hypertrophy, strength, and power block for a 1-month microcycle each. And then the patient athlete has their event for which they are peaked and primed for last. And there's nothing wrong with that, especially as this model is common in some sports more than others, such as track and field. And again, the whole approach is to really develop one physical ability at a time. And if we contrast that to a conjugate model, where we're focused on training multiple physical abilities at the same time, but on different days, this was really popularized by Westside Barbell and the late Louis Simmons. And we know you can't train all abilities at once. Otherwise, nothing is improved upon because it's too much and the patient athletes are going to become exhausted. But essentially, especially if you listen to how Louis advocated to perform it with his athletes, you would have both a max effort and a dynamic effort day, both for the upper and lower body. And in field sports, we can do the same thing. You can have on your max effort day some kind of shock absorption training with max effort work, such as depth jumps or some higher end intensity efforts for low reps. And on your dynamic effort day, you might be doing your bounds and strides and things of that nature. So it can be adapted to the training of the field athlete versus powerlifters like he did. But again, we're just training a couple physical abilities at once on different days within the week. Now, a concurrent model is very similar to a conjugate model as we're developing multiple physical abilities simultaneously, but this usually occurs within the same training session or day, utilizing things such as contrast sets. Undulating models are nonlinear in nature and essentially involve altering the training principles I've already discussed, so volume, intensity, frequency, things of that nature on a daily or weekly basis. So whether we're performing a daily undulating model, weekly undulating model, that's up to us, as the whole approach to this model is really to prevent stagnation because we're providing a wide variety in training stimuli while taking into account how the patient athlete, quote unquote, feels on a particular training day. So we're essentially, it auto-regulates the program based on how the patient athlete is feeling for that day while taking into account the encountered stressors that patient had during that day as well. So things like lack of sleep, how much they ate, school schedule, right? Finals week, usually pretty hectic and crazy for our adolescents, and so on. And really, if we take an example of this model, right, the number of repetitions performed by the patient athlete using X weight on Y intervention, that can be rated on some RPE scale. Usually a lot of people use 1 to 10 in nature. And this is usually based off of reps in reserve as well. And then this information can help us determine how much weight the patient athlete would use the next week or the following week based off of how they feel. And, you know, without getting into the specifics too much, you can also do this by measuring bar velocity or speed in highly motivated patients utilizing works put out by Dr. Mann, among others. And then finally, in terms of our periodization models, there's the triphasic model that I'll touch on here, popularized by Cal Dietz, and it's exactly what it sounds like. You're just dividing training into 3 distinct phases: eccentric, isometric, and concentric from a muscle lengthening perspective. Now, which model is best, as I've already alluded to, depends on the individual in front of you and their goals, training history, injury history, their age to a degree, and so on. So for example, if I have a young pediatric athlete who sustained an ACL injury and I'm currently rehabbing them, I'm probably going to start with a linear model. Probably not going to right off the bat go into an undulating model or a conjugate model. But over time, and I'm talking months or years here, maybe I'll progress them to that point. So again, periodization just involves the development of specific physiological and performance outcomes at predetermined time points through drilling that requires the patient athlete to develop it mastery while becoming unconscious, competent performers in a sporting environment that requires perception, reaction, decision-making, and so on. And some models, such as the conjugate and concurrent, lend themselves more to a vertical integration model versus others which lend themselves more to the horizontal model. Linear and block models come to mind here. And for example, we know that there's different effects on different qualities. So the qualities of aerobic endurance and maximum strength, we know, degrade at roughly 30 plus or minus 5 days versus that of anaerobic glycolytic endurance or strength endurance, as these qualities degrade at a rate of 18 plus or minus 4 days and 15 plus or minus 5 days, respectively. And if we contrast that to maximum speed, AKA our alactic work, we only have 5 plus or minus 3 days. So if we're not having our patient athletes sprint at least once per week at a minimum effective dose, this quality is degrading and our patient athletes are losing their capacity to sprint maximally, AKA they are getting slower. Now, in terms of progressing the patient athletes' movement mechanics and really their locomotive strategies, as we've seen in that previous video, I usually start the patient athlete in the sagittal plane, then I progress them to the frontal, and then finally I end up in that transverse or rotational plane. From a plyometric perspective with field work activities, I'm going to start with the basics jumps, and then I'm going to progress to leaps, hops, and bounds, while finally ending up in different sprint variations and really just using different shock methods. And then we can always add more sub-descriptors onto any of these things I just mentioned, things such as non-counter movement versus counter movement jumps and hops. And again, then we can progress these things into double versus continuous variations of each as well. Now, I'm talking about a lot of stuff pretty quickly here, but the fact of the matter is, myself included, no one individual is properly equipped to deal with all the factors for proper ACLR rehab. You need a team, and a proper team should be composed of mental skills coaches, nutritionists to the degree, but definitely sports dietitians, surgeons, athletic trainers, physical therapists, strength and conditioning or physical preparation coaches, psychologists, sports scientists, biomechanists, and so on. You need a team. And really, I've already talked about a lot of this stuff already. And there is, just really for time's sake here, another video. I took more of a novice athlete, AKA my wife, and I tried to break down some of the movement strategies and locomotive strategies that I went through previously in that smaller video here more in depth.
These videos here in the appendix will be more
Now, this is just out of a program that I am developing, an ACL program, where, I don't know, there's a couple thousand interventions in there, but really I try to put the pieces of this puzzle together more from a practicality standpoint. So this is just one of the videos. But like I said, I really dive in depth here onto some of the change direction mechanics that I like to teach my patient athletes. But the big takeaways when we're teaching change of direction, using whatever locomotive strategies we need to, is that, right, the braking forces are going to be angle dependent. So with sharper or greater change of direction, you're going to need more steps versus if you're performing a cut that isn't quite as sharp. So, right, you're going to need less steps in, say, a 45-degree cut versus a 180-degree cut. And obviously, with the greater the angle or the greater the cut that we're trying to have our patient athletes perform, you're going to have longer ground contact times, lower velocities on approach, and just you're going to require longer deceleration distances for greater cuts, which is why I said, while I like to teach my change of direction mechanics to my patient athletes in threes, have I taught in 2 steps? Yeah. Have I taught in 5? Sure. It's just more of a way for the patient athlete to conceptualize some of these concepts that I'm talking about. But really, right, when we're teaching change of direction, which trying to refine that movement so that our patient athletes are still beginning some of these change of direction maneuvers as late as possible, while still within that patient athlete's capabilities and while still ending up in an effective plant step position. So there's just a couple slides after this, more conclusion slides for this presentation. I'm just going to let the video play here. That way, hopefully people can read the subtitles, and that way if any questions arise on some of this, I can answer that. Okay, so that'll conclude my direct talking.
Alrighty, I was just waiting for that video to finish up. Ian, thank you. We appreciate it so much. Thank you everyone who attended. We do have a quick poll for you guys to take, and then please go ahead and put any questions you have in the Q&A feature at the bottom. I'm going to go ahead and open the poll. We do really appreciate it when you guys take the time to answer. This should just take a few minutes. And while you fill out that poll, or once you're done, feel free to enter your questions. Okay, it looks like quite a few of you have taken the poll. I'm going to give you guys another minute and a half. So if you haven't taken that yet, please do. Looks like we do have some questions coming in. Okay, thank you everyone. I will leave that poll open just as we get started with the Q&A. All right, Ian, first question. How do you measure psychological readiness for return to play?
So as a PT, I want to obviously practice within my scope. A lot of times we'll use outcome measures. So whether you want to use the Tampa scale of kinesiophobia, ACL, RSI, things of that nature. And then obviously if those outcome measures come back and the outcome isn't good from that patient athlete, then a referral to a psychologist or other provider is usually made.
Okay, awesome. Thank you for answering that. All righty. You probably covered a few of these, but just what are some of the most common pitfalls you see that set athletes up to be re-injured?
So first I would say is, a lot of times us as providers will neglect that non-surgical leg. And we know that there's a slightly greater incidence of injuring that contralateral leg after an ACL repair or reconstruction. So make sure that we are targeting both of the patient athletes' lower extremities, because at the end of the day, right after surgery, even that non-surgical leg is becoming deconditioned. The second thing I usually see is when our patient athletes are squatting and then later on jumping, hopping, things of that nature, a lot of them don't perform these activities with a good knee strategy. They definitely compensate by using a hip versus a knee strategy. And like I hinted at in the presentation, we need to get their knee over their toe so that we can reinforce good jumping, landing mechanics, good deceleration mechanics, and things of that nature.
Awesome. Next question. Any differences in teaching change of direction mechanics before an athlete is injured versus after?
Yeah, I mean, one of the big differences is going to be my aggressiveness. And, like I kind of hinted at in the presentation itself, it's going to depend on the caliber of the athlete in front of me in terms of what techniques I'm using with them and how I teach it. But if I have a pretty healthy athlete overall, and, let's say they're a high school athlete looking to get a college scholarship or something like that, sure, towards their junior, senior year, will I start being more aggressive and teaching two-step breakdowns and things like that? Yeah. Versus when I'm in rehab, unless if it's like a professional athlete, I won't teach that 2-step. I'll teach 3, 4, 5 steps.
Okay. Awesome. Next question. Could you give an example of how you would make a periodized ACL program?
Yeah, so I just don't want to give away too much information, but let's see here. Can you guys see my screen still?
Yeah, we can. Sorry.
So here's the program I've been working on, and really, this is quote unquote the field card, and then this would be
Hey,
the.
Ian, I think it's a different screen that we are seeing. I think this
Okay.
is video.
Let's see here. Let's see here. Let's see if I can stop this,
Perfect.
and then.
Let me know if you need a hand. Okay, hang tight, everyone. Thank you. Just to review, the question was, could you give an example of how you would make a periodized ACL program? Go ahead, Ian. Oh, let's unmute you.
Okay, can we hear me now? Okay, so this would be week 1 of the program I've made, and this is quote unquote the field card, not that we're doing anything on the field. And then that would always be associated with a weight card. And what we can see here at the first week, it's not applicable. Really, the first month or so of this program is me trying to show how to morph things like a physical therapy home exercise program into a strength and conditioning program. And that this will flip here on week 3, field card not applicable, weight card becomes more applicable. And then eventually here starting, we'll have a field and a weight card. We can see that field card right now is not super filled in by any means. And we'll just keep on progressing here till eventually we'll get to one of our strength hypertrophy microcycles here, where it starts becoming more filled in. And this is really the start of my triphasic phase for my hypothetical patient athlete here. Recovery methods and all that are in there. And then eventually, right, we'll transition more to our linear mechanics, where all these drills change. It's pretty extensive. And obviously the weight card is going to change in line with that as well. And this will just keep progressing from our transition to our linear to our multi-directional phases that we can see here with some of these drills, to eventually more of our performance phases, where I'm essentially giving a hypothetical in terms of progressing our patient athletes back to sport by gradating practice time, game time, things like that.
Awesome. Okay. One more question. If you have any questions, please feel free to still stick them in the chat. Okay, how do you shift from the PT to the strength and conditioning coach? When and how would you start to involve that strength and conditioning coach?
So part of it depends on your relationship between the PT and strength and conditioning coach. Initially, like I wouldn't have a problem initiating at 1 month. Obviously, the strength and conditioning coach should be trying to preserve the hypertrophy and strength of the patient athlete's upper body, core, things of that nature. Because obviously, as a clinician during that time, I would be focused on that surgical knee. Now, if the question's more, hey, when would you involve that strength and conditioning coach for the patient athlete's movement mechanics, change of direction, developing the sprint ability and repeatability, things of that nature. You know, I've done it at 3 months, 4 months, 5 months, 6 months. It just depends on the caliber of the patient athlete in front of me, the knowledge base, communication, a lot of those variables. In terms of when do I flip the cap, so to speak, I think there's always I'm always using both. I don't think you can just say exclusively, hey, I'm in rehab mode and now I'm in strength conditioning mode. I think that's one of the advantages to working in both sectors, and having a knowledge base in both.
Awesome, thank you. That wraps up the Q&A portion. Ian, thank you so much for your presentation. Great information. Thank you everyone who attended. And we will hopefully see you guys at our next monthly webinar. Ian, thanks.
All righty.
Bye, everyone.